moving into our next session here, just talk about some newer protocols in the vascular lab, and then we have some case studies. But Deanna's one of our vascular techs in the lab. She is our protocol police and make sure that we stay within our protocols and keeps us honest for our interpretation criteria.
Okay, guys, I'm Deanna, and today I'm going to talk about dialysis access, which I feel isn't as commonly talked about in the vascular world. This is a topic I've always been intrigued by, and I'm always eager to learn more. And I also want to introduce you to a new, less invasive option for our dialysis patients. Dr. Lasar is actually leading the way in our area with this new technology. I, back in May, had the privilege to go to Tampa to attend a conference, and actually was able to learn from the Wavelength team there. And then I was able to bring that knowledge back to share with our lab. Dr. Lasar and everyone at VIC, we're really excited about this new endeavor, and we believe that we're on the cusp of something really, really great. So let's get started. So what is kidney disease? Chronic kidney disease involves a gradual loss of kidney function. Your kidneys filter waste and excess fluids from your blood, which are removed in your urine. In the early stages of the disease, most people do not have symptoms. As the disease advances, dangerous levels of fluid, electrolytes, and waste build up in your blood and make you feel sick. You may develop other problems like high blood pressure, anemia, weak bones, poor nutritional health, or nerve damage. Because kidneys are so vital to so many of the body's functions, kidney disease also increases your risk of having heart and blood vessel disease. Once kidneys fail, dialysis or a kidney transplant is needed to stay alive. Some stats here, kidney disease affects an estimated 37 million people in the U.S., which is about 15% of the adult population, or more than 1 in 7 adults. Approximately 2 in 1,000 Americans are living with kidney failure that is treated with a transplant or dialysis. And of course, we know the most common causes for CKD are diabetes and hypertension. So for many years, patients with chronic kidney disease have had very few choices for access. So we have our native arteriovenous fistulas, we have our prosthetic grafts or AVGs, and then we also have our long-term venous catheters, which, as we all know, has a high rate of infection. So traditionally with a surgical fistula, this would be created in your non-dominant arm. The surgeon makes a cut in the skin where the artery and the vein are joined together by making a small opening between them. This procedure will leave an approximately 4 centimeter scar, and it's traditionally created either at the wrist or in the elbow region, so the options there are pretty limited. Some of the types of surgical fistulas, you've got your radiocephalic fistula in your forearm, your brachiocephalic in the upper arm, brachiobasilic in the upper arm. You also have your straight AV grafts, your loop AV grafts, and then in those rare instances, we have the hero graft. So for those of you who scan surgical fistulas, you probably know that they can be pretty tedious and pretty lengthy. There's a lot of things that we look at when it comes to those. We're going to check the inflow artery, the outflow or anastomosis, the outflow vessel, looking for stenosis, thrombus, aneurysms, pseudoaneurysms, looking for any branches that may be stealing flow, checking your flow volumes. Is there a seroma, a hematoma? Is there an infection? We're also going to look at the venous confluence or venous anastomosis. We check the central veins also, because sometimes a patient with a swelling in their arm may have a central vein stenosis that we can treat to help improve those symptoms. And then sometimes we also perform a still study when a patient presents with hand or finger symptoms, because in some of the more awful cases, the patient can lose use of the hand altogether. But bottom line, there is a higher potential for complication in the surgical fistulas. So VIC is on board with this new and exciting and minimally invasive procedure that does not require surgery. I mean, this is huge, y'all. groundbreaking. So reasons why we love it: for one, no scarring. I mean, how many patients have you seen with arms that look like this? And it's, you know, a lot of these patients really don't like that. They don't want to have that. So if we can avoid that, let's do it. So the need for secondary interventions to maintain patency is much lower than with surgical AVFs, which is really important for those pre-dialysis patients because it decreases the likelihood for multiple procedures and a contrast hit to the kidney every time. We don't have to use the non-dominant arm because there's essentially no risk for steel. And then no aneurysms. I can't tell you how many new patients we see in the office that are using a perm cath for dialysis, or they're not on dialysis at all yet, and they know someone or have seen someone with a huge fistula in their arm. And they are really put off by this. They don't want it. You know, they're looking for any other way, or maybe they don't want to have a fistula at all because it's, you know, off-putting to them. So this procedure may offer an alternative option to allow patients to feel comfortable and confident with the decision to try an endo-AVF. The created fistula results in a shared flow between the cephalic, basilic, and brachial veins, which may account for the low incidence of subsequent complications. It offers increased opportunities in vascular access. Since the upper arm vessels all receive blood flow from the anastomosis in the forearm, it makes them all potential conduits, and it can facilitate combinations of cephalic and basilic vein cannulation zones, whereas with your traditional surgical fistulas, you only have one option for venous cannulation. So really, what's not to love? So endovascular AVF, how does that work? So arterial and venous catheters are inserted percutaneously and advanced to the target endo-AVF location. When placed in proximity, the magnets in each catheter attract, pulling the vessels together and aligning the radiofrequency electrode. The venous catheter delivers a burst of radiofrequency energy to create the connection between the artery and the vein. And then sometimes during the same procedure, they may coil a brachial vein to redirect flow to the superficial vessels and then to support maturation. Let's see if I can get this video. Nope. Do I touch it? Or do you? Okay. Maybe we can get this to work. Well, I thought if I pushed it again it would work. I don't know. Either one. May not have time. I'm sorry, y'all. Not working? Oh, sorry. So catheters are each inserted into an artery and a vein in the arms through a small puncture or incision. Using fluoroscopy, the catheters are advanced to the appropriate location for creation. The magnets in the catheters allow them to precisely align while pulling the two adjacent vessels closer together. The venous catheter, which contains the electrode, delivers a burst of radiofrequency to create a connection between the artery and the vein. So if you guys get a chance, pull that up. It's a pretty awesome video. I'm sorry that it didn't work. So for pre-op imaging, the most important thing for you to understand is perforator. So I know in our vascular experience, we're all used to looking at perforators in the leg, and it probably sounds pretty foreign to see a perforator in the arm, but I promise you, once you see it, you can't unsee it. And if you're struggling to see it, then it's probably not there or not big enough. But don't despair. You can always try the other side. Don't give up hope. Some of these patients have just a trash perforator on one side and a beautiful, juicy one on the other side, and we love that. So again, perforator, we want that to measure 2 millimeters or greater, and they want this to be ideally non-tortuous. So if your perforator is below 2 millimeters, then you're done with your wavelength protocol. Just go ahead and go forward with your normal labs protocol. The outflow veins, cephalic and basilic, in the upper arm, we want those to measure 2.5 millimeters or greater. At the creation site, which would be in the fossa, we'll want the radial and ulnar artery and at least one of the paired veins to measure 2 millimeters or greater. And then same for the access site, which we could use the brachioradial or ulnar artery, and then we want at least one vein to measure greater than 2 millimeters. It's also important to note if vessels are calcified or if waveforms are abnormal. And important things to note, these things really help the surgeon figure out the best course of treatment. So if you have a high bifurcation or if one of these superficial veins don't communicate with the perforator, your doc really needs to know that. And then that'll tell us too later in our post-op imaging what's going to be the dominant outflow, or is this going to be a split flow fistula. And then other tips to help your veins grow. Use a tourniquet, sit your patient up, keep the patient warm, keep the gel warm, whatever you can do to just keep those veins nice and plump. So here are some ultrasound images from a patient that we did preoperatively. The cephalic vein is measuring well over the 2.5 millimeter mark. We love these juicy veins. Same thing with the basilic vein. I've found in my limited scanning of these, since we hadn't been doing this for very long, that the basilic vein seems to be the larger vein, and not that that's always which one takes off post-operatively, but pre-operatively I'm seeing that a lot of these basilic veins measure a lot larger. So here's some images of the perforator. I just took a few off of several patients just to kind of give you just a guideline of how it may look when you're scanning down the arm. And then I throw color Doppler on there too, just to make sure we're getting good flow. Oh, this was a nice perforator from one of our students. Really nice and juicy, we love that. So these are two more. Oh, it's gonna work. Okay, so this is just doing a scan down the arm, starting in the upper arm cephalic, just coming down, we'll get close to the fossa, and there's the perf going to the deep system. We're gonna turn in long here, and you'll see the cephalic vein going towards the thumb, and then the perforator going to join the deep system. So anywhere you wanna, anywhere you can measure, you can do it in long, you can do it in transverse. I think most of the guys with the wavelength crew say, let's do it in long. But this is a good view to try to get with that. And then let's scan down the basilic vein, starting in the upper arm, coming down, getting close to the fossa. We've got a branch there, and then our median cubital vein. And then there's the perf there, gonna turn in long. And then there's your basilic, your median cubital vein, and then your basilic veins bifurcated earlier and went towards the pinky. So once you have gotten a greater than 2 millimeter perf and everything looks good in wavelength land, then you can continue on with that protocol. You want to get your brachial artery and veins again. We want at least one of the paired veins and the artery to measure 2 millimeters or greater. And then at the creation zone, again, we want 2 millimeters or greater in one of the paired veins in the artery. And then the same thing in the access site. 2 millimeters in the artery and at least one of the paired veins. So these are what our pre-op worksheets look like. We scan these into our EHR, and I think most of the time I try to save a copy and give it to Dr. Lassar to have on hand. And any notes that I have of anything important, like if one of the superficial veins don't communicate with the perf, or if this patient has a high bifurcation, or I think I had one that had an ulnar artery stenosis. I noted that on this this worksheet so that Lassar has an idea of what kind of plan he wants to go in with. So I showed you the other slide of all the things we do with a surgical fistula when it comes to imaging, but post-op imaging for these endo AVFs are a lot less tedious and a lot less complicated. So what you need is your inflow to be greater than 500 milliliters per minute, and in the outflow, basilic and or cephalic, you want a diameter of greater than 4 millimeters and a depth from the skin of less than 6 millimeters. You want your inflow artery and your basilic and cephalic for split flow, or if only one communicates with the perf, then just that one, to add up to at least 70% of your brachial artery or your inflow arteries flow volume. So again, these are much less complicated than the surgical fistulas. This is our post-op worksheet. Currently we're following these patients every 2 weeks, and it seems to be working out pretty good in our favor. I mean, we do struggle with patients that live out of town making those appointments, but we also have patients that are coming in from out of state just to see Dr. Lassar because they have read about this procedure and it being offered here, and they're really into it. This is a patient that we did that has a left ulnar artery, ulnar vein, endo-AVF. And in that same procedure, Dr. Lassard did angioplasty of the basilic vein, perforator vein, and the ulnar artery. And we've got a brachial artery flow volume of 882. And then we come to the cephalic and basilic veins, where your cephalic is really low at 36, but your basilic vein is 849. So this fistula is on its way to maturing because we take the brachial artery inflow and that basilic vein outflow and add those together, and we're pretty close. So hopefully this will continue to mature, or not go any other direction, and we'll be good to go when it comes time for cannulation. This is a right radial artery vein endo-AVF, and in this procedure, he did coil the medial brachial vein, and we got a brachial flow volume of 1352. And so then we come and take our flow volume in our superficial veins, and in our cephalic vein, we've got a 830, and in the basilic vein, we have a really low, like 126 flow volume. But something to note about this particular patient is that the basilic vein did not communicate with the perforator. So we're really not concerned with that basilic vein. Our cephalic is going to be our dominant outflow. But since the basilic doesn't communicate and the cephalic is only giving us 830, where's the rest of that approximately 660 milliliters per minute going? So this is when I'm like, okay, so they've coiled the medial brachial vein, so let me take a flow volume in the lateral brachial vein, and that comes to almost 500. So that's the extra 500 we needed to get closer to that brachial artery flow volume. So in the future, Dr. Lassard may need to coil this lateral brachial vein to improve maturation in this particular fistula. So just in short, Wavelength offers us new and very, very exciting options for our dialysis patients. This has been like the first change in dialysis access for 20-some years, so there's going to be struggles, and we're doing our best, but hang in there. We're on our way to something really groundbreaking, and I feel fortunate to be a part of it. So thank you, guys.
Okay. Well, hello again this afternoon, and that was a wonderful talk, and I'm going to completely switch gears now, and we're going to go into abdominal vascular structures and how we do this. And you've moved the screen away a little bit further. There we go. All right. So again, I just have one disclosure. Nothing happened from morning to afternoon. And we're going to talk today in this session, about what vessels you want to evaluate when you're asked to do a mesenteric duplex scan. So this would include the aorta, the celiac artery, axis trunk. There's lots of names for that, celiac, the superior mesenteric artery, and the inferior mesenteric artery. And these are just some example signature waveforms where we expect the vessels that should be low resistance. We want to see them low resistance, and higher or intermediate resistance, that we want to see that in our signature waveforms. And I'm going to take you through some cases to take a look at this. So the protocol requirements are that, first of all, evaluate the abdominal aorta. And we're going to get a velocity waveform at about the level of the SMA, but we want to really take a look at that aorta. If the aorta itself has some significant abnormalities, that would be taken into consideration when we're looking at the mesenteric vessels as well. Do look at the takeoff of the celiac and the SMA off of the aorta in, again, the more proximal section of the abdomen in grayscale. So I do encourage you to take color off. Can every patient be seen well? No. But many of our patients, we can see those origins very nicely and look for the presence of plaque, or even the angulation of it can change a little bit about what you're doing. So then pulse wave Doppler is going to be, again, the proximal aorta. So when I say look at the aorta, we don't spend a lot of time doing that in general, but scan down the aorta to look for any abnormalities, aneurysm, dissection, stenosis, anything like that. I did have one patient that, as a very early mesenteric duplex scanner, I was fascinated by all the flow going out the celiac and thought I had found one of those things, and the aorta was occluded. So there was a lot of flow going out those vessels, but the aorta was occluded, which I found out fairly quickly. So pulse wave Doppler, aorta proximal to the takeoff of the celiac artery. And then you want to look at that celiac, not just at its origin, but at least proximal and distal. You may or may not include the splenic and hepatic branches. In general, if everything looks normal there, take a quick shot or look at it with color. SMA, proximal, mid, and distal. So not just the origin or what you can see if you stay in one position off of the aorta. And then the IMA. So how many of you have IMA listed in your mesenteric protocols? Oh, good, look at that. How many of you don't do mesenteric duplex in your, good. I don't see any hands going up. So IMA, and it's not as hard as you might think as you first start doing these things. So let's talk just a moment about the abdominal aorta. It should be, the normal adult aortic velocity range is generally going to be somewhere between 60 and 100 centimeters per second. And we're not talking about renal duplex where we absolutely rule out that aortic velocity as being good to use in the ratio if it falls below 40, but it's something to take into consideration when you look at absolute velocities. So, and then we want to look, again, the aorta should narrow as you go further distally. You should see it tapering. And the normal infrarenal diameter is going to be 2 centimeters or so, about. An ectatic aorta is going to be defined by an aortic diameter that's between 2 and 3 centimeters. And we have a different waveform pattern. If I can't really see the takeoff of the renal arteries or can't really see much in that proximal aorta, if the renal arteries and if the celiac are low resistance vessels and you're up higher than those, you will see, and if you just take your Doppler and move it, just track it down the aorta, there will be a change when you pass those renal arteries from a more low resistance to intermediate resistance to a higher resistance. And again, that's a good clue to use, but that also assumes that those vessels are normal, that the iliacs are normal and other things. But it has helped me at times to know when I'm above and below the renal arteries to look at that waveform change. And this wonderful, gull wing appearance that happens if we get the beautiful shot from the aorta, which is in this one. Let me see if I can get this to, where's our little pointer? Pointer? Good. Aorta and transverse, the celiac, hepatic, and splenic. And I'm sorry I can't do this on both sides easily. Okay. Now, so the celiac. And here are our criteria, which I am not going to read every bit of this to you. But in the celiac, we are looking at normal waveform shape as being a rapid upstroke and a lower resistance. It's feeding the hepatic and splenic beds, which are generally high metabolic beds, and so you will have a lower resistance. Once you get a velocity that's over 200, and very importantly, in this type of stenosis, if you think it's a stenosis, it should act like a stenosis and show you post-stenotic turbulence. You may even see, if it's a very tight stenosis, post-stenotic dilatation. So we look for that dividing line. Occasionally, you will see a celiac artery that is occluded. And if it's occluded, as you go out to the hepatic and splenic, much like if the common carotid is occluded, you can still see that reversal of flow going from one to the other. So do look at that in the hepatic and splenic, whether or not those are open, and if there's retrograde, which there usually will be, more often from the hepatic artery filling. So when we look at median arcuate ligament compression, or the Mal's syndrome, which can happen, we have a pinching off or a compression that happens where the median arcuate ligament is compressing the celiac artery, and you'll see velocities that go up and then normalize again, as we've heard with other types of things, compression syndromes. It's something that can be relieved and isn't a fixed lesion. It does happen more often in women. It also happens more often in very thin people. So I always say that as we get older and we gain a little bit of weight, my celiac used to have a very tight stenosis if I laid down, and when I sat up it was fine, and now it doesn't do that anymore. So, okay, the SMA and the IMA. Pretty much the same criteria for both of these, but you look at velocities that, again, absolute velocity going over 275 centimeters per second, and you look for that poststenotic turbulence. The SMA can be followed usually down the abdomen, paralleling the aorta to the left of the aorta to about the level of the umbilicus in many, many, many of our patients. And again, if someone really is coming in for a mesenteric ischemia exam, these patients are often thin. They haven't been able to eat if they truly have mesenteric ischemia, which I'll talk about in a moment. It has to include at least more than one, 2 out of 3 of those vessels, or all 3, for that to really bring on that whole syndrome. However, we do see stenoses in one or the other, or disease, aneurysms and other things. So for SMA, remember that it's 275 is the number we keep in our heads. Greater than that with poststenotic turbulence, and with celiac, it's going to be 200. Again, occlusion is going to be documenting that there is no flow, and know that especially in the mesenteric system, everybody likes to help everybody out there, and you will get lots of collaterals. So look at the SMA or IMA. If it's occluded at its origin, it may reconstitute with all of those big collaterals. Now, that's the criterion. Again, you can find these in many of the reference books. I highlighted this. This is criteria that is from our beautiful VIC group here, and I just highlighted some of the things that I didn't mention. Note, again, the 2 out of 3 criteria, and then there are some ratio values that you can use comparing to the aorta. You also want to know that you'll have different criteria for stents. And again, these are published, these are out there. So as you look at your own and look at your comparison studies, you'll decide what works best for you. So as we move along in this, one of the main things to watch, of course, in any of our studies, and if you've done any reviewing of other labs, because I know all of you are using good techniques, but angle correction is crucial. Leaving the angle at 60 when it's not at 60 in terms of its lineup to the vessel walls is going to create a lot of problems. Your velocities will change. If the angle should have been smaller, lined up with the artery, that estimate of velocity will go down. If it should have been bigger, the estimate of velocity would be larger. So you know which side you erred on, but you need to line it up. And these are not going to lie always at a 60-degree angle like we think it should. It may not do that. Look at the aorta and take color off to look at the aorta. Look to see what's there. This one has a dissection, and it's actually fairly high in the abdomen. You need to know this. And so look at it with color and Doppler, both spectral and color Doppler, but look at it with color off as well. This was a very interesting one in that you could, with color on, easily see color filling in a nice laminar or nice kind of contained, didn't look like an aneurysm, till you took color off. And then you saw that there was a saccular aneurysm here with thrombus in it. You still have the flow channel being a fairly normal size and not having many changes, but nice to know there was a saccular aneurysm here before you start testing. And then you see the celiac and the SMA coming off anteriorly here. Now with this, we see this kind of high color aliasing and what looks like a narrow celiac. This one is behaving nicely, or aorta and transverse, and it's standing straight up. If it is, then you're going to use a very, very low angle towards 0. When we look at the cosines of the angles, anything less than 30 degrees is going to be really almost equivalent to what it will be at 0. But we want to correct to the vessel walls, and this, of course, this is a high velocity. It has a sound as well that tells you this is stenotic. If you did not hit that origin, but you come out and you're a little off of that, if you get this type of waveform that has a velocity that's come quite a bit down, this has a delayed upstroke. This should tell you in any bed that you're in the arterial system, something is more proximal to this. Okay, so here's another one. This one's laying more on its side, and we can see the high velocity always document the post-stenotic turbulence, PST. These are older slides, still very relevant though, that patient supine with a high velocity, if you're seeing a high velocity in the celiac, and especially if it's the only disease you're seeing, sit the patient up, and it normalized as soon as the patient sat up. Or you can say take a deep breath to relieve that compression, but it's harder sometimes to do that, to get into the place. Most of the time it was much easier for me to just have the patient sit up. So this is an example of proving that this is a compression syndrome and not a fixed lesion. Okay, let's look at this one. Here's the aorta. And again, there are some charts out there for using ratios, 3.5 compared to the aorta. But here we are going out into the SMA. Now, what do you think about this waveform in the SMA? Does it have a rapid upstroke? Come on, I know it's after lunch, but give me some nods anyway. Yeah, got a rapid upstroke. It has a nice sharp peak, but does it look like an SMA in a patient, which again, you have to ask them, are you fasted? Now, if this patient is not fasted, this might be perfectly normal, okay? I remember the patient that told me that they were fasted, they'd only eaten something light, and it was like light was 3 donuts. I said, that's not fasted, but they're light. Okay. All right, so here we go, and we're going out into the proximal SMA. And in the mid-SMA, this is another reason to go all the way out. This didn't look bad. It's hyperemic, but something happened, right? Something happened on the way to the distal abdomen. So this is a stenosis any day of the week with a bruit. You can see the spectral bruit. And this was done by a colleague of mine who has since passed away, but was in our profession for over 45 years. Took this beautiful picture. So instead of just saying there's a mid-SMA stenosis, what does this look like? Well, it's enlarged. It was a dissection. Okay, so we're getting excited that there is a stenosis here. Looking again, this image was critical with a thrombosed, and this gentleman was only in his mid-40s. First question was, did you take a blow to the abdomen or something else that happened? This happened very suddenly for him. Okay, post-stenotic turbulence, follow it down. Okay, beautiful pictures, beautiful pictures. All right, then he was put on aspirin therapy. So here we are at the origin of that, the whole vessels again, proximal. And my colleague did the first study, I did the second study. And I had to go back to the chart, because just watch what happens as we go through these images. Proximal, mid, and distal. And I'm thinking, what happened? You know, and there's the filling. Okay, I didn't include that, but this thing filled completely. So I'm going back to the chart and looking at what she had done, and aspirin therapy, and he cleared it. So, but I was, where is it? She found it, why can't I find it? And this is what we did. Okay, so IMA usually gives people a little bit of the shaky knees. Can I find it? Can I actually see it? And here's the IMA, and the way to find it if you have trouble is to follow the aorta to the iliac bifurcation, come up a little more proximally, and it will pop out like a little pumpkin stem or apple stem coming right off of the aorta. In transverse is the best way to see it at first, so you'll find it. And then you want to see it, usually will lay kind of in a tortuous manner and follow down the aorta. But here's the IMA, and here's an image that it's not from this one. There's a nice view of the IMA origin. But in this patient, you can see it laying out there. So let's say this is the first image you get. You're sure it's the IMA. What a beautiful shot, right? What's wrong? Does this look like a normal IMA? Even if the patient weren't fasted? No, because it has a delayed acceleration. It should always have a very rapid one. Here was the origin. So if you get a delayed acceleration, you want to go back and look. So now I'm going to quickly take you through a patient who was the perfect storm. And I found this image, and I like it because it does look like the branches are not being well fed, and there's the lake right there, right? So I thought this was kind of good for that type of thing. So here's a patient that came in. They'd had an SMA stent put in years before, someplace else, came into our lab. And here's the aortic velocity. Again, I know it's above the renal arteries because it has a nice lower resistance pattern. All right, so let's see if this one will play. Then we look at it and we get that wonderful clue, right? A color buoy, just basically, you know, color kind of splashing out everywhere. And you can see that the SMA is here, or I'm sorry, the celiac is here, and the SMA is just below it. So here's the celiac, all right? And remember, we have to have 2 out of 3 to really be sure that mesenteric ischemia, the collateral potential in the belly, will take over for a lot of disease processes there. But we have the color buoy, we have the spectral buoy, and we have the waveform that is rather convincing, okay? Go out a little bit, poststenotic turbulence, very convincing, right? So, looking at the splenic and the hepatic arteries, are they going in the correct directions? Yes, they are. So both of them are still going in their correct directions. And then we look at the proximal SMA stent, which eventually those multiple sample volumes, extended range are coming on, because this is high. This is very, very high stenosis, right? So again, as we look at this, you can see a little bit of where the stent is, which again, taking color off or doing a color compare, you can see where the stent is, and now we can kind of tell where the stent starts and stops, and it gets even higher. So this is just, we're trying to not alias and go up even higher. When you want to get rid of aliasing, you can lower that baseline, give it more headroom basically. You can expand, you can take the PRF up to the point that it won't go any higher. And the third way, in case you forget it, is to lower the Doppler carrier frequency. So if I really needed to resolve something, and in this patient it was fine to do with the curved linear, but I might even go down to a phased if I need to drop the carrier frequency, which will give you more velocity potential to display, take the PRF higher. So distal to the stent, oh my goodness, yes, everything is completely showing you that this is a serious, serious stenosis. And then we hit our little IMA. Okay, so this patient came in, and they had lots of time that they've been building this up. They did have a fair amount of collaterals, I guess, going in, but this was the absolute trifecta of all of that. And so that's what I wanted to share about mesenteric stenosis. As you look at your new machines and your beautiful machines, this is my first machine back in 1982. I go back further than most of you. And it had a monitor on the side. It had a monitor on the top. When you push the foot switch, then the the top monitor with the image would freeze and the Doppler would show up on the side. So between the foot and the hand, and the fact that I'm very tall, but pushing this down the hallway was, I would be looking around side to side. There was no adjusting anything. But yes, it was very knob intensive and was a mechanical transducer. So, yeah. Thank you.
Thank you, Tish. Those were some great aortic and mesenteric pictures, and I can't believe they made you take that machine portable. I can't believe that, actually. I've been asked to announce that the drawing for the vendors is going to occur at the end of the day today, so stick around to the end of the day and see how many people hit you up for a free drink later if you win. We're going to introduce Heather Ridge. She's one of the vascular sonographers at VIC. She graduated from vascular school at 2015, and she's been with us for 4 years, and she wanted me to let everybody know that she is not nervous at all.
He's got jokes. So I was excited when I found out that we were doing a whole day of ultrasound at the conference. And then Tina approached me and was like, I need you to do a case study. And I was like, oh, I'm not excited anymore. But then I was just like, this is what I'm passionate about vascular ultrasound. So I was like, I can do this. I always tell my patients, when you say you do ultrasound, people think babies. And I'm like, no, I do vascular, and I really love it. So I'm doing a case study on a popliteal aneurysm. And just a little background about aneurysms that most of us all know, that it's a localized enlargement of an artery caused by the weakening of the artery wall. A popliteal aneurysm is the bulging and weakness in the wall of the popliteal artery, which supplies blood to the knee joint, thigh, and calf. Popliteal aneurysms are associated with abdominal aortic aneurysms in 30% to 35% of patients. Causes, a number of factors can play a role in developing a popliteal aneurysm, including atherosclerosis, high blood pressure, and trauma. Some risk factors, tobacco use, age. Aneurysms occur most often in people age 65 and older. Being male, men develop aneurysms much more often than women do. Ethnicity is another. So Caucasian males are at higher risk of aneurysms. A family history is also a big one. Having a family history of aneurysms increases your risk of having the condition. Symptoms, a popliteal artery aneurysm may not cause many noticeable symptoms, making them difficult to detect. But if you do have an enlarging popliteal aneurysm, you may have complaints of pain of the lower leg that occurs with walking, knee pain, swelling behind the knee, and pulsing sensation behind the knee. Some complications of a popliteal artery aneurysm. They include thrombosis, rarely rupture of the artery. Thrombosis of a popliteal artery aneurysm can cause a severe lack of blood flow in the lower leg, which may result in the loss of a limb. Sudden leg ischemia can cause the following signs and symptoms: a change in skin color, no pulse behind the knee, or skin in the affected area feels cold, or even some numbness. Here at VIC, our protocol is, if there is the presence of an abdominal aortic aneurysm, we image the common femoral and popliteal arteries bilaterally. The criteria, common femoral is defined as aneurysmal if there's a focal dilatation of 1.5 times the proximal segment, or 2 centimeters. Normal popliteal is less than 1, and aneurysmal at 1.5. So this case study, Man presented to the Vascular Institute. He's a 52-year-old male. He was a truck driver. Past medical history of hypertension, high cholesterol, and a right lower extremity DVT. A history of tobacco. He had smoked 4 packs a day for multiple years and then resumed later with vaping. Patient was told 3 to 4 years ago he had a 3 to 4 centimeter aneurysm in his right lower leg. Patient was uninsured at the time and unable to have any type of surgical consultation. He has a recent history of significant right leg swelling with recent visit to the emergency department out of state. At that time, he was negative for DVT, and the CTA reported a very large popliteal aneurysm measuring 7 centimeters in the right lower extremity. Patient was placed on Eliquis due to the thrombus in the aneurysm, and swelling has improved since taking Eliquis for 1 week. So he came to VIC and followed up with one of our nurse practitioners, and when they do that, we do a same-day duplex ultrasound. He was sent for CT and was told to continue with the Eliquis and follow up with the surgeon after these results. So then we did the ultrasound. The right popliteal aneurysm was measuring 6.3 centimeters with the residual of 1.7. The right common femoral measured 2.2 and the left common femoral measured 1.7. He had a right ABI of 0.86 with anterior tibial and perineal occlusive disease. The left ABI was 0.74. His left SFA was occluded, and the left popliteal artery was not visualized adjacent to the vein. And come to find out after, Dr. Harris actually told me that he had an event weeks earlier that he was at a truck stop and had severe pain, and come to find out, we think that his other popliteal had ruptured, and he managed to keep that leg. Findings on the CTA, partially thrombosed popliteal artery, additional aneurysms of the bilateral common femoral, and a right internal iliac measuring 3.2. So he's aneurysmal all over. That's a nice pretty picture of the thrombus in that right side. So he followed up with our surgeon. They recommended he undergo a right femoral to below knee bypass. We were going to obtain a lower extremity vein map. And then he also recommended stent graft placement in the right internal, approaching that from the left given the right CFA aneurysm. Surgeon is very suspicious of Marfan syndrome. This guy was really tall, slim. About 90% of people with Marfan syndrome develop changes in their heart and blood vessels. This includes the popliteal artery, although it's rare. A little bit about Marfan syndrome. It's a condition that affects your connective tissue, and that's what provides support to many of the structures throughout the body. In Marfan syndrome, the connective tissue isn't normal. As a result, several body systems are affected, including your heart and blood vessels, bones, tendons, cartilage, and lungs. The cause of Marfan syndrome is caused by a defect in the gene that enables your body to produce a protein that helps give connective tissue its elasticity and strength. And some of those symptoms for Marfan's vary from person to person. It's tall and slender build, which is in this guy's case. A breastbone that produces outward or dips inward. A high arched palate and crowded teeth. Heart murmurs, extreme nearsightedness, an abnormally curved spine, and flat feet. So the plan for this guy was between the MP visit and the surgeon, the patient began to have occasional left upper chest pain, so we're currently waiting on a cardiac clearance before undergoing any intervention. Thank you.
Thank you, Heather. Good job. Our next speaker is Melissa Warren. It's my honor to introduce her. She serves as one of the planning committee for the SVU annual conference. She's an SVU mentor. She is the senior manager of clinic operations at Emory Healthcare in Atlanta, and she also works with a bunch of other educational endeavors. So it's our honor to have her come up to present another interesting case study, please.
So before I got up here, I was sending Chad a text because he said, I can't find your bio. Can you give me some updates? So I gave him a quick little bio, and then I also said you can end it with, I was so excited to get here that I got pulled over last night for speeding. So welcome to Tennessee. This is my first time being in Chattanooga, so thank you guys. So a little bit different approach I'm going to take here. Whenever I present out case studies, I like engagement. So I'm going to pause throughout this, and I want to see if you guys can provide me some feedback, just as we kind of walk through it. So this is a patient that is very, very near and dear to my heart. I think I've been monitoring him now for about 6 years. So yeah, about 6 years. So no disclosures. So let's talk about our case. It's a 47-year-old male that presented to a transplant clinic for follow-up 8 days after his renal transplant. He had persistent nausea and vomiting for about a day. He was hypertensive, so his BP, whenever he was being checked out, was 219/110. And whenever they pulled his labs, his creatinine was at 14. And so for those of you that don't know, upper scale here is about 1.3. So from there, I think the decision was made. It's pretty obvious something is going on. So he was admitted to the ED, and they basically arranged for him to go immediately to the ICU. He was having a hypertensive emergency, volume overload, and so they initiated HD, renal biopsy, and a duplex. So I'm going to start at the very top and kind of work my way down. But the initial ultrasound that was done inpatient, they had documented that the EIA and EIV were completely patent. They did document an area of increased velocities at the proximal anastomosis, but basically said, other than that, there's no distal disturbance. It looks okay, so perfusion's not an issue here. But then we go to the biopsy. And so as they do a biopsy, they go in, they look at the kidney, they look at the cells, they see what they're doing. They come back and they say, there is an acute tubular injury, otherwise it's pretty much baseline, but that's usually indicative of a vascular compromise. But again, we had an ultrasound that said it was fine, right? So they basically said from this point, let's continue to figure out what's going on, right? We need to save this kidney if we can. So they ordered an MRA. So just looking at the MRA, so we're going to focus on the side with the kidney, you can see that it basically cuts off just about 3 centimeters distal to the CIA. There's no flow. There is perfusion of the kidney, which was a little bit unusual, so we were trying to figure out, is this collateral flow that's coming through? But you can see there's no flow in the EIA and even extending down to the SFA. So, and this is immediately post-op. So it's a little bit suspicious, a little bit odd, especially because we had that duplex initially that said everything was fine. And so it's getting a little bit worse. So from there, it was decided it's an emergency. We need to try and not only save the leg, but also save that kidney. So the patient was taken to the OR. It was decided that we were going to start with a CO2 angiogram just because it's a little bit safer than using contrast. And so you can see the wire that's coming up and over. So it's pretty much just a wire here. There's nothing here. But the kidney itself, you can still appreciate that perfusion. So the physician that was treating this patient decided to go ahead and do a balloon angioplasty of that region and throw in a stent, hopefully to tack down what they felt was a dissection just so that they could restore perfusion. But after they went ahead and added a little bit more CO2, they noticed that there was still a little bit of filling defect or a residual stenosis that was right by the anastomotic site coming off of where the anastomosis was. So from there, unfortunately, it was decided we got to transition to open repair. I'm hoping the video plays, but if not, we can just explain it. But from here, so you can see, as we discussed what the original findings were, there's a dissection in the EIA, so we threw a stent down, we tacked it down, and then we did an open revision, so harvested the GSV, went up to the common iliac, and extended it down to the transplant artery. So patient comes in immediately after. We said that the surgery was good, but this is what we're looking at. And so I guess from here, does anybody have an idea what they would think of? So again, thinking through the surgery itself, we did a GSV harvest, that was our conduit, but at the anastomotic site, we're getting velocities that are upwards of 500. Distally, perfusion doesn't look too disturbed, but the acceleration time is over 100, which we know that there's some variability between a native and an allograft. So any thoughts? So sometimes what I would say is color can be a little bit tricky, so can Doppler, especially if we're redoing or revising something, and depending on what the surgical fashion is, you could have a false elevation. So supplement with your B mode. So this is a zoom in just of the anastomotic site. And so you can see there, there's bright texture that's within the bypass itself, right at the anastomosis. It doesn't really look intimal, but it kind of raised the question of, is this a retained valve leaflet from the GSV that was creating an issue? So being that we know over time, these vein valves can produce stenosis and or compromise any sort of area that we are bypassing, we elected to take the patient back to the OR, doing a CO2 angiogram, balloon angioplasty twice using 2 different sizes. But one thing that's important to point out is, so after they did the revision, and you can see it here as it's running, the direction of where the bypass is relative to the CIA, it's almost parallel. And so being able to actually differentiate that on imaging intraoperatively was a little bit difficult for the physician. So here, you know, kind of further documenting it, it is parallel. It was difficult for him to appreciate any sort of narrowing or stenosis. He did elect to go ahead and perform that angioplasty and move forward. And then after, he did a completion angiogram, and he said everything looked fine, right? So comes back to us, disappointing again. And so he's back to us. We're doing our ultrasound again. Creatinine scores at 2.4. Blood pressure still is elevated, and now I'm still getting a max velocity of 522. So back to the OR. So attempting to do a CO2 angiogram, electing to transition over to IVUS. It's not too impressive. It can't really identify or produce or tell us that there's a specific lesion that we're looking at. But the physician felt at the time, let's go ahead and do a balloon angioplasty to see if we can open this back up. Perhaps again, there's that valve leaflet that's being retained and compromising the kidney. And again, documenting out that it was pretty difficult to see, but we went ahead and proceeded. So from here, comes back to us. Once again, a little bit disappointing to see. So blood pressure is now 201 over 104, creatinine's now at 3. And one thing that we like to do and just kind of point out, and so the anastomotic site, it looks like it's filling pretty well, but again, because he used a cutting balloon, we're gonna come down, focusing on right here. So this is still part of the bypass. This is actually the distal anastomosis into that transplant. And so here, you know, you kind of see the irregularities that are sitting in between the bypass itself, and so it looks almost as if somebody's been chewing on it. So it was an injury as a result of that cutting balloon. So from here, this patient's gone to the OR 3 times now, right? So we've got a kidney transplant, we've done an open repair, we've gone back for 2 different angioplasty procedures, and the physician has documented many times that we've been able to see this very, very clearly on ultrasound, but he's struggling in the OR. So what do we get to do now? That's where I come in. And so ultrasound guided case, where we go in, we're looking at the transplant. So from here, it's more so a multidisciplinary and a multimodality approach, where we have 2 different viewpoints. So physician on his side doing CO2, I'm on my side doing ultrasound. I show him exactly where we're going, we get in. Pressure gradient measurements, we're looking at about 30 millimeters of mercury between the CIA and the bypass, so we know that there is something there that is limiting flow. And you might have to play this one for me, because yeah, it's stuck. Thank you. So first thing that we want to do, can we just do a balloon angioplasty to that region? Can we open it up without having to do any additional intervention? So intraoperatively, after we do the first balloon, we can see that the velocity, which was prior going intra-op, it was around 500. Now we're at about 383, so it's not very impressive, right? It's not great for us. And so at that point, it was decided we're going to go for a stent. And so again, limitations to the projections with where the bypass was laying. It was really up to me and my team to kind of figure out where we're laying it out, provide some sort of guidance. And so you can see here, this is actually the stent wall on the anterior portion, and on the posterior portion, you can see it line going through right here. So now you can appreciate, so this is the stent that we placed within the bypass, and down here is the stent within the EIA. And again, re-inflating just so that we can ensure that there's complete apposition against the wall. And a completion angio showing that there's perfusion still to our kidney now. So final velocity that we're measuring within the stent is 169. And so ultimately, this case was a success for us. So just after that, he followed up. This was his initial post-op visit. So creatinine was about 2.1. It has been trending downward. You can see now the stent that's sitting right here that we helped to deploy intraoperative. Velocities are still about 171, so much improved compared to the pre-op. And you can see our trend over time for we have him on about a 6-month surveillance protocol at this point, but velocities have remained pretty consistent. So that wraps it up for my case. I just want to say thank you to all of you. No, I didn't get a speeding ticket, it was just a warning. But I do want to say thanks to my team. I can't do it without them. I've got a really good group and I'm blessed, so thank you all for having me.